Thank you, everybody. So, I'm Dr. Jason Bowman. I was a firefighter, critical care paramedic for 10 years before I went to medical school, and I currently practice as an emergency medicine and ICU physician at Ephraim McDowell in Kentucky, where I am the ICU, PCU, and ECMO medical director there. Uh, we're going to talk a little bit about cardiac arrest physiology and how that intertwines with the research in cardiac arrest related to cardiac arrest. And then I'll give you some suggestions that are completely subjective, very little objective to it, but that's the nature of it. And I think you'll hopefully understand by the time we get to the end of this. So, what exactly separates life and death? That's the kind of the main part we have to figure out with cardiac arrest, right? I would say it's close to 20 years ago that I had a 40-year-old patient that I was called out to take care of, initially called out as chest pain. I was en route whenever the fire department called back and said, hey, we're doing CPR now. Get there, guy was in his office, was working a normal job. I'm sure he didn't wake up that day planning on dying. We continue the code. It was a difficult intubation. He's biting the tube the whole time, biting on the laryngoscope. There's teeth going everywhere. He's in VFib. We shock him. We give epi. We give lidocaine. We give amiodarone. This was back when lidocaine was first. We keep doing that. And we worked this guy for nearly an hour, transported him to the local hospital. And we were there whenever the ER doctor pronounced him dead, still biting on his ET tube an hour later. Those are difficult ones to swallow. I'm sure anyone's been working in EMS for any period of time has had that, where they've had a patient that was still alive, had some consciousness induced by the CPR, that you didn't get him back. And those are the hard ones to swallow. There's a cardiac arrest researcher named Lance Becker. He's got a great quote that says, nothing makes you want to make tomorrow happen today than having a patient die on you today that you could save with medicine from 10 years ago, 10 years from now. And that kind of thought process that in 10 years, we might be able to save this guy. You know, we know some of the stuff that people are doing at some places. It's just not widely adopted everywhere. But in 10 years, we might be able to save that guy. That's what got me into doing cardiac arrest research. And that's why cardiac arrest is one of my specialties now. So to tackle the problem of life and death, we've got to figure out what pulselessness is, right? Because that's the key thing, is pulselessness. You know, everyone will die at some point of a lack of a pulse, but that doesn't mean we can bring them all back. When you look at the statistics, only 350,000 patients a year have sudden cardiac arrest. I think it's easier to describe the situation than it is to really define it. You know, the person walking through Walmart that grabs their chest and falls over, the person who is at work and has chest pain and collapses. That's sudden cardiac arrest. That's an untimely death. People that die of stage 4 cancer, their pulse is going to end, but those are not people we could get back. We can understand that. The problem is actually being able to feel a pulse to begin with. And this is where the reality starts to break down. We kind of get it theoretically, but how do we codify this and make research out of it? Well, you have to become objective then. There was a study done, it's been over 10 years ago now, where they took a bunch of paramedics and put them into the cardiac OR, put them up above the drape, and said, feel if this guy has a carotid pulse or not. Some of the times the patient was on bypass, some of them they weren't. If you gave them 10 seconds, they were only 15% accurate. If you gave them 30 seconds, they became 50% accurate. They never got better than 50% though. So that means a bunch of paramedics, probably about the best people in medicine to determine if somebody has a pulse or not, were no better than a coin flip, even in a sterile situation of a cardiac OR, not in the middle of a difficult reanimation in someone's living room. So that's the first problem. We take that and we understand that some patients are going to have no pulse because they're dead. Some of them are going to have no pulse because they have low blood pressure. And that's a difficult thing to kind of figure out between the two of them. There was a oral surgeon in the 1860s named John Hill. He was apparently a good oral surgeon, but a piss poor anesthetist. And he figured out that a lot of his patients would become pulseless while he was anesthetizing them. And if he had them inhale ammonia, a powerful vasoconstrictor, he could return pulse to them. They were no longer pulseless. I wouldn't want him taking my teeth out, but he did figure that out. This kind of got around, and about 40 years, you get a guy named Gottlieb, who is administering adrenal extracts, which is epinephrine, norepinephrine, steroids, a bunch of junk, to patients that he again loses pulses in during anesthesia and gets the pulse back with him. So it's really no surprise to anyone that you're able to restore hypotension with a vasoconstrictor, right? You know, thankfully, this is all 50 years before Pearson and Redding did their dog studies looking at coronary perfusion pressures and trying to bring that up and get us ROSC rates with that. All those studies of which have never been able to be reproduced, but led to us using epinephrine in wide amounts in cardiac arrest at a dose that of 1 milligram that they used for beagles. We're a little bit bigger than beagles. I don't. That's where we're at. But it should be no surprise that we can restore hypotension with a vasoconstrictor. But is that the same as cardiac standstill? Probably not. And that's the problem that we have with research, is figuring out which bucket to put these patients in. If all we can determine is if they're pulseless or not, it's difficult to determine if our treatments for hypotension are going to actually work for treatments for cardiac arrest. These are not exactly the same things. You know, the asphyxial arrest of Pearson and Redding's beagles is not a patient with an MI that goes into VFib. That's not the same thing. But we're trying to use that data to come up with how we're going to treat these patients. And it's what we've been doing for a really long time. So until we're able to really apply maybe something like the Reason trial, where we use ultrasound on the ambulance to determine if someone has a pulse or not, to determine what their true contractility is, if this is PEA versus pseudo-PEA. Until we get to that point, it's going to be difficult for us to have actual good quality RCTs in cardiac arrest. And this is the issue we start to run into is, I'm not saying don't trust your research, but our research really does break down if we have this much crossover between the two arms. So we know again that vasoconstrictors like epinephrine will restore a pulse in someone that's hypotensive. So we definitely should continue using epinephrine in cardiac arrest. That's my official opinion on it. We should. But we need to think about what we're doing. We should probably use it early. Is the dose of 1 milligram the best? I don't know. Maybe half a milligram might work. Whatever we're going to do, we should probably use it early because we want to get those people that are hypotensive and prevent them from going into full cardiac standstill. We want to be able to bring that up, use it as essentially a post-dose pressor. That makes sense. Should we give them 12 milligrams though? I mean, if it doesn't work up front, that's where we need to start thinking about this a little bit. That's where the ACLS stuff kind of gets carried away. You know, is there harm in these patients if they're truly in cardiac standstill? I would argue that there is. So the issue we have here is that cardiac arrest is a different pathophysiology. It's a different physiology entirely than normal circulatory system is. In your normal circulatory system, we have a preload-dependent pump that pulls suction and applies force to create a delta P. And in this case, that delta P is a difference in pressure between the venous side and the arterial side. So we have a pump that's doing this. When we give epinephrine to it, we're squeezing down on the arterioles, but we're also increasing inotropy, and we're squeezing on the venous system. We're increasing that preload coming back into the heart. So we're actually increasing everything, including the inotropy, when someone has a pulse. It's a great push-dose pressor. When someone doesn't have a pulse, though, where's that delta P coming from? Inotropy, it doesn't exist. It's zero. That delta P is coming from an external force, the compressor pushing on their chest. So the best thing to do with your epinephrine is give it to the firefighter doing CPR. In that case, that's where you're going to get your extra inotropy from. Certainly not giving it to the patient. So what happens? The entire circulatory system starts to come back on itself. You have the arterial side and the venous side move towards something called mean systemic filling pressure, around 25 millimeters of mercury, as your venous pressure goes up and your arterial pressure falls. It continues going that way. And what do? We give a vasoconstrictor, something that reduces the diameter of the arterioles, which every time you reduce the diameter by 1, you reduce your flow by a factor of 4. So we substantially increase the resistance against a fixed amount of flow. This causes hypoxia, hypoperfusion, shock. So in my pig lab, this is what we were able to prove. Surgically implanted a carotid blood flow sensor on him and then measured an art line. During CPR, you can see the carotid blood flow starts to go up. The reason it goes up is because of regional hypoperfusion. The tissues release nitric oxide and adenosine on their own. Try to vasodilate. They need more blood flow. They open everything up. Your natural resistance goes down to try to increase blood flow. And what do? We come along with epinephrine. We slam them with epinephrine. I don't know how to do that. Oh, look, that. Slam them with epinephrine and have a 60% drop in the carotid blood flow as soon as we give them the epinephrine. But your map looks good. Yay, high five. We're doing a great job. 3 to 5 minutes later, it wears off and the blood flow starts to return. Perfect time for some more epinephrine. Again, your map looks great. Their brain's toast, though. So that's the problem. We've seen this in pigs. We can demonstrate it. So this is the issue. We're increasing that resistance with the epinephrine against a fixed delta P. So what could we be doing? There's been some research done out there about actually giving vasodilators, like nitroprusside and adenosine. Thankfully, nitric oxide and adenosine are naturally produced by the body. This is the reason why you saw in the Paramedic 2 trial, there was reduced rates of ROSC in the placebo group, but there was increased rates of neurologically intact survivors if you just gave them saline instead of epinephrine. And this is why, because of the body's own natural nitric oxide and adenosine that it's producing. One of the other areas that we might be able to help these patients with is with modulating the venous congestion. This is where you see the impedance threshold device. This is where you see head-up CPR. This is where you see Zoll's rescue pump, where you push and you pull. If you want an arm workout, that's a great one. In Europe, their Lucas device goes beyond 0. It actually pulls. The FDA won't allow that here, though. These are all things to consider that we might be able to do in the future, is providing more flow, more delta P. Again, going back to Lance Becker, he talks about the electrical, circulatory, and the metabolic phase. What that really means, though, is that the cells are what's going through cardiac arrest. We focus on the cells, we think about the cells. That's really what we're going to try to save out of this. It's your brain cells, your heart cells, your liver cells, your kidney cells. And what are they going through? During this time, the epinephrine, all of these adrenaline, these agents like this, are actually toxic to your cells. They increase the demand for ATP in a time when you have no oxygen coming into the cells. They're going to be more likely to push them toward apoptosis and necrosis. Nitric oxide and adenosine, on the other hand, they're actually protective to the cells. Once again, we see where potentially even just the placebo of saline might be the way to go over a whole bunch of epinephrine for these patients. There's a lot of things that we could potentially do. You hear some people talk about remote ischemic conditioning. Things like applying a tourniquet to an arm reduces the amount of EF reduction that you have in STEMI patients. These are smaller studies, but there's something there. You're actually able to bring the theory and show that there is a benefit to patients. These are all areas we should be doing more research on and things to think about because they're low-hanging fruit. So this is the issue with it, is how are we going to jump to the next stage? How are we going to get across that? And that is difficult, but we have to stop and think about it and recognize that ACLS already has demoted epinephrine. They have demoted all of this stuff. They have changed their most recent guidelines in 2023. They introduced an entirely new set of guidelines, a bunch of great recommendations in there that should all be a moment we kind of stop and rethink how we're taking care of cardiac arrest. Are we doing it the best way? What we did in 1950s is not the best. So how can we do this? How can we go forward? Well, unfortunately, as I've said before, our RCTs are kind of trash. They have a lot of crossover between the two arms. So it's difficult to understand, it's difficult to interpret. So I'm going to give you some suggestions. The first suggestion that I have is just say no to drugs. There have been no drugs that have ever been shown to improve intact neurological survival from cardiac arrest. None. However, every code we run, what do we see? Get the epi, get the bicarb, get the calcium, get the amino, get the lidocaine, get more epi. How about some D50? How about some saline? How about this drug? How about that drug? That's what we see. I mean, I used to give 500 milligrams of aminophylline to every cardiac arrest. We'd do anything if it was a drug, except good CPR and good airway management. That's a little too much. So that's the issue here. The Paramedic 2 trial has shown us that epinephrine does not produce more intact neurological survivors. It'll give you more zombies, but it won't give you more people that go home and hug their family and know who their family are. It won't give you more of those. Actually, I had a little bit less people walking out of the hospital. But we still give it to everybody, right? So maybe we rethink our dosage. I think for most of my guys, we're talking about 1 milligram up front and then 2 half-milligram pushes. We're talking about half-milligram up front, 2-3 times, much smaller doses, and then there's a limit to it. So what's the health benefits on the sodium bicarb? The problem is, again, not an increased rate of ROSC. When you give sodium bicarb in cardiac arrest in these hypoperfusive states, what you'll see is that it makes the oxygen hold onto the hemoglobin more, and so it disrupts your oxygen hemoglobin dissociation curve. You can see that in your actual patients. If you have a super sick patient with their SATs in the 90s, you give them a bunch of bicarb, you'll see your SATs go up to like 99, 100%. You didn't make them better. You just made it hold on to the oxygen harder, and you'll actually increase intracellular acidosis, again, killing your cells. Same kind of thing happens with your calcium. The muscles actually spend much more energy pushing the calcium back out of the sarcoplasmic reticulum than they do bringing it in and having the contraction. It's the relaxation phase that takes that. So we're going to slam a whole bunch of calcium into these patients and make it harder for us to get the calcium back out. It doesn't help. Unless you have a good reason to give it, unless there's a reason, it doesn't really help. So what do we need to be doing? We need to be doing good CPR. I advocate for the Lucas device. That was one of the main things that my pig lab looked at, was the Lucas device versus manual chest compressions versus the auto pulse. Lucas device, hands down, won every time. Was that an RCT? No. Was it in humans? No. But when you look at the Minnesota Heart guys, you look at all these people doing ECMO, these really high-level advanced eCPR places, they won't do it if the patient wasn't coming in on a Lucas device. There's a reason for that. They believe in it. So it's something to think about. At a minimum, should be doing kind of pit crew CPR, something. Focus on doing great CPR. And this is the most mindless, easiest way to do it. Personally, I'd prefer a definitive airway. We know that the RCTs are out there. It's not sold one way or the other, but I think that it's certainly the thing to think about is definitive airway. Until we get to a point where we're not intubating the patients first thing when they roll into the ED, when the ED physician stops doing that, then I think EMS can stop doing it. And then finally, definitive ROSC. So this is why we started the ECMO program where I'm at. And it's because it's the definitive way to get ROSC into a patient. I hear a lot of people argue about ACLS versus ECMO, things like that, about should we do one, should we do the other. This doesn't ever happen until ACLS has failed. That's the point. I'm not putting people on this the second they become pulseless. It takes me 20 minutes just to wheel the equipment into the room. So those are already being down for about 20 minutes by that point. What we're doing is we're putting this on people that we can't get back. We're putting this on my 40-year-old that's biting at the ET tube, that every time we shock him, he flinches, that we just cannot get out of VFib. That's who we're putting this on. And I got the opportunity in my 4th patient that we put on ECMO to have exactly that, where the patient was in persistent VFib, had not responded to any of the drugs we'd given him. And we pushed play on the ECMO machine, and he came out of VFib into normal sinus rhythm on his own without being shocked. Just the flow from the ECMO machine. I'd never seen that before. It works. And we're working with Jessamine County EMS. They were the first ones that I know of in the state to adopt a protocol like this. We've now got Bull County, Garrett County, a lot of the other surrounding counties to our hospital that have similar protocols to help us identify these patients in the field and give us a heads up 20 to 30 minutes before. Remember how I said it takes 20 minutes to get that equipment into the room? We now have a door to cannulation time on average of 15 minutes. Our quickest was 12 minutes. They hit the door to our ER and we had them on ECMO flowing in 12 minutes after they hit the doors of our ER. That kind of stuff couldn't happen if we didn't have these heads up from EMS. Working with EMS to limit the epinephrine, decide where to take these patients. Some of these guys have come from a really long ways away. Jessamine County's bringing people sometimes a 30-minute ride to get to my hospital. And you may ask yourself, is that a smart decision? Why should they do that? What should the limit be? How far should you go? Well, I would ask you, what else are you going to do? That's the whole reason we work them on scene, right? Is because the hospital can't do any more than what we can do in the back of the ambulance. It's not like they've got better epinephrine. Well, some hospitals can do more. UK has the equipment. U of L has the equipment. We're the only ones that have someone in-house to cannulate 24/7. But I was just at UK last week giving a talk on this exact thing. There's a lot of people that had a lot of interest in potentially doing something more like this. This is going to come down the pipeline over the next few years. And what we're going to see is we're going to start saving patients in the next few years with technology like this. And it's going to require EMS to work with us to pick these right patients, give us the heads up, and then get them on the pump, get us definitive ROSC that way. We've only been doing this for 2 years. We've done 31 patients, and there's now 10 people walking around alive that wouldn't be otherwise. All 10 of those people, every one of them, if we'd said not an ECMO candidate, the next thing that we would have done is pull our watch out and say the time of death is this. So that's something to think about. So that's all I have for today. A lot of stuff to think about, hopefully, but open any questions. Yes, Hollis. We had last year on 13 patients, 38% with a CPC score of 1. Thank you. Yeah, we were very excited about that. We did not follow everything that the Minnesota Heart guys and the Alfred guys do, which that's where you're going to get your arrest trial and your 2-cheer and cheer trial from, is those 2 guys, which are shown in the mid 40% survival range. But they also limit it, like Minnesota Heart. If you've been down for more than 30 minutes, they won't put you on ECMO. But we knew we wouldn't be able to get that many patients with being as rural as we are. And so we eliminated a downtime line. So we actually had a patient that arrested walking through the parking lot of a Walmart in Harrodsburg that was taken to the satellite hospital there in VFib. They couldn't get him out of VFib, but he was biting the tube. And they put a Lucas device on him and transported him from that hospital to Ephraim McDowell in VFib with a Lucas device running. He was down for almost 90 minutes total. And we put him on ECMO, and we discharged him from the hospital 2 weeks later. He was 73. This is not like, a 19-year-old or something. And the most amazing thing to me on that is this guy had not driven in 10 years. He got his driver's license back after ECMO. And he's now like out and about and is like really involved in his community. This is one of the only people I've ever heard of that actually got better after that kind of thing. So I guess that's the thing. You got these big guys that really put a lot into this stuff, like Jason Bartos. They're doing 150 of these a year. Okay, I'm not doing 150 of these a year. I'm doing 12-ish a year. Okay, and they're saying don't be a pessimist, be an optimist. Try hard on everybody. Just try. The more people you put on ECMO, your survival percentage may go down, but the more people that will survive in the end. You're going to just save more. The more you try, the more you're going to save. And that has never proven to be truer to me. I cannot tell you how many times that I have rolled my way back from the ED with some poor schmuck on ECMO, and everything's flat, and everything looks terrible, and I'm tired. It's 2 o'clock in the morning, and I'm going, what the hell have I done? I've just created a zombie. I've just put this corpse on a nice little warming machine. And then they live. So I think that's the thing. It's gotten our nurses, it's gotten our ED really galvanized around this because they see cardiac arrest as something that's potentially beatable, which it makes sense. For us to put someone on ECMO for ECPR, the NNT is 3.3. How many other things in medicine have an NNT, a number needed to treat, of 3.3? The number needed to treat for aspirin to save a life in a STEMI is 360. So you have to give 360 STEMI patients an aspirin to save one of them. Who's going to take a STEMI to the hospital without giving them aspirin, though? Nobody. Of course, they're going to do that to everybody. Now, this is 3.3. To save a life neurologically intact with CPR, with ACLS, it's 45. I have to do it 45 times of ACLS to save one life neurologically intact, and this is only 3.3. I mean, this is like the biggest advance in cardiac arrest medicine since the invention of CPR in the 1700s that was then forgotten for like 200 years and brought back by Peter Safar. So, sorry. So I would not cannulate until we've tried ACLS for 15 minutes. That's one of the areas in which you see some problems in some of these studies, is certain studies like the Inception trial, which showed there was no benefit of ECMO. Half of their patients still went on ECMO in the control trial because they were randomizing it only 5 minutes in. So that's a problem. You got to be careful with that. So I go with the 15 minutes. They got to be down for 15 minutes before they're an ECMO candidate. You've got to at least really try it on ACLS. Thankfully, it takes about that long to get everything together. And so I'm not saying we don't start. We get them back, we put them on ECMO, and then I give them a couple days. You have two hard points. If they continue to have cardiac asystole for more than 6 hours, you're done. Their heart's dead. You've made a bad choice somewhere. The story was wrong. Because the patient has to be less than 65, witness to rest, bystander CPR in any rhythm other than asystole. Now, that sometimes they come to you in asystole, but the initial rhythm was VFib. That's okay. We get those people back. But sometimes you hear a story of, oh yeah, this patient's, was in VFib and now they're in asystole, and you actually get to them and you see them, and they've been in asystole the whole time. That guy was never in VFib. It happens every now and then. But you're usually able to figure that out pretty quickly. I've only had one patient that's happened to so far where the story was way off. What really happens is because if you're only saving 35-ish% of these patients, that means 2/3 of them are going to be dead, right? Even in a perfectly good setting. It's brain death is what it is. And that takes about 2 days to figure out. And so the important thing is we have to have these conversations really early with the family, right up front. Tell them what we're going to do, tell them what to expect, tell them how bad everything is, and tell them when we're going to stop. And that if we show no signs of neurological or cardiac recovery, we will take them off ECMO. They don't get a choice in that. Now, I'm not saying the patient's going to die, but they're going to come off ECMO, and then whatever happens, happens. Those kind of things, those conversations have to be had early, and thankfully we have a rock star palliative care team that helps us take care of that stuff with the families up front. And so our average time on ECMO, is about 2 days, which is really, really short. But that's a lot of our eCPR patients, they bounce back and they don't need it 12 hours later. Yes, sir. Almost none, which I would not have expected. I expected to have a lot more barriers than that. I got very lucky whenever we started that. So I'm the director of the ICU, so I'm the one that has to deal with all the fallout of a bad patient selection. So that helped quite a bit. I wasn't dumping these patients on someone else. And so I'm the one that has to deal with it. And I have a really wonderful intensive care partner who had never taken care of an ECMO patient before this, but he was willing to do it and ride the line with me. And so we've really built this from the ground up. I had a great ICU nursing director that was, again, 100% on board with this. The company that sold us the equipment was really good about bringing in and doing training. But I will say that our first case was January 9th. Our first training was March 1st. And so the first 4 cases we had, me and my ICU nursing director had to stay at the hospital and couldn't leave for 2 to 3 days while they were on pump. So that was difficult. But we had a lot of great cardiology support up front. We did our third case, we did ECPella, where we put an Impella in on ECMO. I thought we would never do that. We've done it 4 times now. Our first case, we did a pulmonary embolism thrombectomy on ECMO. There's less than 6 hospitals in the US that do that. But me and my interventional radiologist partner were crazy enough to do it. And thankfully have really smart friends we were able to call and say, hey, you do this regularly. How the hell do you do it? And they were able to talk us through it, and it really wasn't that bad. And so, call some really smart people, figure out how you're going to do it, and then just do it and save lives. And we've thankfully it's worked. Yes, sir. No, sir. Not yet. Been busy. Yeah. Yeah. So 12 months into this program, we had a great piece of equipment. The one that was up there a second ago, really small thing. It was like a bucket, some tubes, and a pond pump, and a tiny little oxygenator. You dumped 4 liters of saline into it, picked it up, it primed itself, and you plugged into a patient. It was a dumb ECMO machine. It had absolutely no monitoring capabilities. It was weak. It was meant originally to be an RVAD, a right ventricular assist device. So you could turn it up all the way to max and you were never going to hurt anybody because it was a really weak ECMO pump. But it was enough to keep people alive. And so that was a great equipment for us, for dummies like us that just wanted to get some blood to go round and round in a circle and some air to go in and out through an oxygenator. Because I'm still a paramedic at heart, and that's all that matters in the end. And so it worked great for that. And then they promptly left the market January 1st of 2024. And they were our training company and our equipment company and our dilators and our wires and our catheters and like everything. And so we spent all of 2024 scrambling, buying up extra ECMO pumps that we could find on the black market and all the other random places to just have enough stock, and then trying to go to our administrators and say, hey, you've let us put 15 people on ECMO and a handful of them have lived, and we haven't sunk the entire hospital on the financial side of things. Please give us $1 million and buy us new equipment. And they did. And so we spent all of 2024 scrambling, and we are still reeling from a lot of that. We found an ECMO education company to take over, and they did terrible. They came in and basically taught us how to do pediatric heart transplants on ECMO, and we're like, this is nothing like what we're doing. Like, but that's all they had experience in. And so we had to get a new company in, and it's been a mess. But I would love to publish some of this stuff and talk about it. I think that's the point of it is it's not me. It's not my other doctors. It's us just trying. We see these people as potentially savable, and it's just some dummies out in BFE Kentucky that are putting people on this miraculous machine, essentially, almost, that makes blood go round and round and the air go in and out on patients that's not working on anymore. And combining that with some halfway decent EMS guys that are doing good CPR, they're calling us, they're spotting the patients, they're bringing them in on time. My ED guys are willing to bust their butts, figure out how to put these lines in, and then put them on, and it's working, and we're saving lives. And I think that's something that could be replicated anywhere. You don't have to be these amazing places. You've got to be UK to do heart transplants and lung transplants. And I have certainly sent my fair share of patients that became much more complex to UK because they need that. But there's this lower level of we just got to get some blood to go round and round, and that's a need where we're figuring out how to fill. All right. Thank you, guys.